Welcome back, everyone. You are now amongst harm reduction greatness in Washington State. A real treat for you in this next 40 minutes. I'm Susan Kingston with the Center for Community Engaged Drug Education, Epidemiology, and Research over at ADAI. And I'm very happy to moderate this discussion with these members of harm reduction greatness here in Washington State. And I'm going to invite them each to introduce themselves and where they work and what kind of work they do. And then we'll jump into our discussion. So Peter, you are unmuted. We're starting with
I get to go first, huh? First of all, thank you. Thank you for that introduction, and thank you for allowing us to be here. I have been in harm reduction for like 12-ish years now. Actually, I guess a little longer. Anyhow, and it has been a varied and wild ride, to say the least. I came to harm reduction. Well, I didn't come to harm reduction. I still am in harm reduction and as an injection drug user too. So I am not lived experience, but living experience as far as that goes. And so I have a much different, probably perspective than some of our other great esteemed presenters today, which I think just is kind of always my main point is that there is no one kind of drug user out there. There's no one kind of path for that drug user to be on, and there is no one, end result. So anyhow, that's who I am. Oh, and I guess I work for I work for Project Neon, which is a great program that got started by King County and predominantly is focused on men who have sex with men and meth use. When it got started, it was an HIV prevention program. We have grown and expanded a little bit, but we are still very meth centric and just because of our history. So yeah.
Great. Thank you, Peter. So Peter is coming to Seattle. Christina is broadcasting live from Mason County.
Good morning, everyone. As Susan mentioned, my name is Christina Muller-Shinn. I work at Mason County Public Health and Human Services. We're a rural county on South Sound, kind of above Olympia on the way to the Olympic Peninsula. We have a lot of really rural, expansive areas. We have one kind of city, Shelton, so I'm here in Shelton right now. So we have, I work at our syringe service program. I've done lots of overdose prevention, naloxone distribution work. I have about 20 years of experience working at syringe service programs with some breaks in between, but I just innately believe in harm reduction. And I'm, really passionate about talking to people who are currently using, talking to people who, maybe not be using. A lot of my work is informed by my lived experience of using substances, traveling around the country, living unhoused. And I've done work in urban areas. I started work in the Bay Area in California, and I've done stuff in Oregon and in Washington.
Great, thank you. And live from Spokane, we have Sam Carroll.
Thank you, Susan. I am working in the syringe exchange at Spokane Regional Health District. I've been here at the health district about 10 years. I have been in this field about 20 years, starting out as an SUDP, working in methadone for many years, also inpatient, outpatient. This is kind of the culmination of my career, which I am harm reduction passionate also. I work with a great team here at the health district. And yeah, that's where we are.
That's great. It is complete coincidence that we have representation from cities starting with S. That's just a complete coincidence. So my first question to each of you is really, what are you seeing right now in terms of meth use among the folks that you work with? And if anything is, particularly changing or dynamic about that right now? And Sam, I'm just going to toss that to you first.
Well, as far as meth use, we unfortunately aren't allowed to hand out any smoking supplies. So most of the people, if not all of the people that we see, are using meth, at least using meth. As far as the dynamics goes, they're very uncomfortable about what's in their meth. We spend a lot of time demystifying that is the fentanyl is in everything, trying to break that myth, talking about testing substances, but also making sure that people aren't scared of everything that they're using.
Interesting. Christina?
Yeah, similarly, I would say that methamphetamine is probably the most prevalent substance of use in our community. Maybe alcohol would be above, but at least of the people that I'm working with at either the SSP or general outreach, methamphetamine has always been the #1 substance. Of people who are using opioids like fentanyl back in the good old heroin days, I would say about 95% of people using opioids also use methamphetamine. And then there's a whole swath of people who only use methamphetamine or stimulants. We are also seeing people very concerned about what's in their meth. I do think that we did a disservice when we started distributing fentanyl test strips back in the day, because they have such a high false positive rate when testing meth, that we really kind of, I think, inflated this myth that there was fentanyl in everything, and people were really afraid. So we're really trying to change that. What we're also seeing is a lot of deaths in our county due to psychostimulants. So again, we are seeing our opioid overdoses, but we're also seeing a lot of people who are passing away where meth is the only substance in their system. When I started doing this work in Mason County 7 years ago, I just started talking about overamping, about some of the kind of acute risks, both psychological and physiological, around meth, and really found that people who have been using meth for a really long time did not know that you could have, I struggle saying overdose, but overamping, but fatalities using methamphetamine. So that's something that we've worked really hard to increase that education around. We're also seeing a lot of people having just complicated health issues. People who are having a lot of health concerns, who are not engaged in medical services. Maybe they have been diagnosed with heart disease or diabetes or some of these other kind of comorbidities, and they have not been taking their medication for years. A lot of oral health issues, teeth issues is a huge concern. Dental is my #1 referral request at the exchange. That's something I've been really passionate about and really building up, as this kind of stimulant oral health program. So those are some of the things. But I would also say we're also not allowed to give out glass pipes for smoking. So a lot of people who use methamphetamine who aren't injecting just don't find our harm reduction programming relevant to them. They don't think we have anything for them, so they're not engaging in services, which is a real bummer, because we are not just a program that gives out supplies. We are not transactional. We have a lot of connection to resources and support. So that's been a real challenge, is getting people who only use meth to think that coming to our program is relevant and that we have something for them.
Thanks, Christina. Peter?
Yeah, I agree with much of what has already been said on that. I think and I think it's well within the community of meth users as well as outside. I completely agree. Most people don't think you could die from meth. Most people think it's a relatively safe thing. There's also I'll use it so I won't die from opioids, which is completely false. So there's a lot of misinformation. And I agree that we probably did stimulate some of that misinformation when we first came out with test strips. What I find really interesting is that and I am very fortunate, because out of King County and a long history of successful harm reduction in the Puget Sound area, which got started in Tacoma. But anyway, so we have a long history of being well supported. Even that, though, I think it amazes me that I have fentanyl test strips and xylazine test strips, and those are the only thing that we can kind of have access to. We're already using test strips off label, so it is frustrating that the science isn't out there to provide a product that is directly and for harm reduction work and being able to do some testing to find out, if meth's got method and that sort of thing. So yeah, so drug checking is a big deal, and I realize that the machines are very expensive, but they are starting to get into the market, so that's really a positive thing. I think people are starting to get a little bit more better information, concrete information about what they're getting. So yeah. But yeah, I think even amongst the people who use meth, I think there's this sort of lackadaisical, if that's all they're using, there's sort of this lackadaisical, oh, well, all of that harm reduction stuff or all of that recovery stuff or all that scary stuff is over there and it doesn't apply to me. And I think that is not true. And a lot of that comes from the fact that the funds are coming from opioid money. And so it's very targeted to other people that don't apply to me, kind of thing. And I think that can be very dangerous. But yes.
Sure. Question for any of you to answer. What are some of the challenges or needs that you think are unique around methamphetamine as compared to opioids, or when perhaps in combination with opioids? How do we distinguish between the real common messages we're hearing around opioids and opioid overdose?
I think one of the things that is different, and it was mentioned in one of the earlier segments, is that while an opioid overdose, as I have witnessed them, can be somewhat slow. People nod off and then their breathing goes down and down and down until they stop, right? So it's kind of a slow motion thing. However, it is pretty immediate after they consume their opioids. And I think for meth-related deaths, it can be hours and hours and hours later, and there's maybe not a very significant lead up to it, like they're alive and then they're not. And whereas opioids, you can sort of watch that happen, and it's much easier to go, oh, hey, I think I need to step in. And of course, then there is also with opioids, you have medically assisted treatments that you could be programs you could be part of. You have an overdose reversal medicine that's very available in most places these days. None of that exists for meth, or at least not as well talked about and FDA approved and that sort of thing.
So different overdose.
Different overdose and different treatments.
Lack of options for folks. Christina, Sam, other.
I would add to that, we refer people to treatment on a regular basis, and when people come and they're only using meth, I'm really at a loss because there's nowhere to send them that's going to be effective. I mean, inpatient treatment is not going to address the depression and anhedonia that they're going to experience when they're withdrawing. So I really don't know where to send them.
Christina, other thoughts?
Yeah, everything that both Peter and Sam said ring true. Regarding treatment, I think that there really aren't as many options to support people. It seems like a lot of the more treatment modalities are really more focused on opioids or alcohol. Contingency management is one of the most effective evidence-based treatment for methamphetamine, but that is not prevalent. I'm not sure, I don't want to say anything untrue, but in my county, there's no service providers that I'm aware of that are using contingency management. I think it sounds a little radical for some old school treatment providers. And so I don't think our society is really pivoting and shifting as quickly as it needs to accommodate these specific things that really work for stimulant use disorder. I also see less motivation with people who are using stimulants to stop their stimulant use. At the SSP surveys, the biannual SSP surveys that ADAI does, we see a lot more people who are interested in reducing or stopping their opioid use and not as interested in reducing or stopping their meth use. I also think that holistic health is a particular need. There are some mechanisms with methamphetamine that are harder on our bodies. So the lack of appetite, stimulants really suppress appetite. So we see a lot of malnourishment. There's a lot of physical changes that are associated with chronic meth use that tend to be a little bit more visible. And that I think just creates a lot of stigma in society. Employers or people, if you're renting a house, sometimes there are some signs with, loss of teeth, etc., that immediately somebody can sometimes recognize, oh, this is somebody who either uses meth or has a history of using meth. And there's also a lot of internalized embarrassment and shame from people who are exhibiting those kind of physical symptoms. And then lastly, I would say that Peter touched on this with, opioid overdose. We have naloxone, this kind of magical thing that can bring someone back if you get them in time. Whereas with methamphetamine, we're really seeing it being accumulation of chronic use, how it's affecting our organs. So the prevention for methamphetamine associated deaths is really upstream. I mean, this is like many, many years in the taking, and I think we'll be hearing a lot more about that later today. But getting people engaged in medical care and dental care early enough, I think would be is maybe the only way that we're really going to help curb some of these meth associated deaths. And that's just a real challenge because we know that the medical system is not always very kind to people who use substances, and the same medical options or medication options that are offered to somebody who does not use substances oftentimes are not offered to people who use methamphetamine. It's kind of like, stop your drug use, and then the conversation doesn't end there. So and I think there's a lot of room for us as providers to work on that, to have conversations. And I think that's going to be one of our next things that we'll talk about. So I'll expand there.
Christina, you're just a good plug for all that's coming in the future in this session and all afternoon. So all that Christina said, we're going to be talking about a lot more this afternoon. So I definitely encourage you all to tap in after lunch to explore some of these resources that feel lacking. And so with that, with a lack of sort of stuff to be able to give people and what feels like a shorter list of resources and referrals to offer people, you're really left with conversation, like relationship building and conversation. So I'd kind of like to ask you guys, and we've heard this a lot from providers and from other panelists already today about engagement and how that can just feel so much more challenging here. So I'd like you to share like what you have learned as successful strategies to, connecting with folks who may be more distrustful, experiencing different levels of mental health situations with their meth use or not being on meth sometimes. And just how do you connect? How do you establish trust? And how do you keep those relationships going? Peter, do you want to start us off?
Sure. I will gladly speak to that. It's very related to stigma. I think that establishing trust and building a relationship, very often the stimulant user comes into the situation with the guard up already. A little bit of my personal story, when I started using meth, which, by the way, I did everything out of order and differently than that is typical for a lot of folks. But anyway, when I started meth, my teeth were already a mess because I had bad oral hygiene. So I remember in the very first months of using meth that it would come up. I'd be like, oh no, this was here before. I mean, all my missing teeth were because, yeah. Anyway, and I remember feeling very very much like I had to say that and share that because I didn't want to be that tweaker guy who, anyway. So yeah, it is, those signs are there, like Christina said, and all the association with those signs being a bad person are there from both sides, right? So that's already a battle. I think patience is probably the one word that I would use when talking about building trust or getting a connection going. You have to be patient. Not everybody is going to be on the track that you want them to be on. As a matter of fact, the fact that you have a track that you want them to be on is probably your first sort of mistake, right? Yes, we want the best for the people that we care about, but it really is up to them to self determine that, and it takes a while for those stages of change to happen, and you can't push. The harder you push, the harder you get pushed back. So, um, and the other thing I would say is, if you're trying to make a conversation, is find out why. What about meth use is so attractive? Because it's different from most people, and I think it speaks to the where you get people that are more interested in that survey, where more people are interested in cutting back on their opioid use. That's a pretty clear cut thing. It's like, I bait out, I can't get a job, I wake up, having vomit on myself. All these things that can kind of happen when you use opioids that don't necessarily happen when meth. Why do you like it? What good is it? And there's a lot of really fun or positive things that come from meth use. There's also a lot of crap that comes from it. So yeah, I think to just automatically demonize it and into this elevated place above, say, caffeine or nicotine or alcohol or all the other drugs that people use regularly that also damage their body is, probably not wise.
Okay, so patience, learning a little bit more about motivators and how people benefit from their meth use, and not showing
And what they want,
Yeah,
they
what
want
they
to
want.
accomplish. Yeah.
Sam, is there anything else you'd add? And what's been successful for you?
I would say listen, listen, listen.
Mm.
Getting to know people on a personal level. Like, if they usually come in with someone and they're not with that person, oh, where's so and so today? Or remembering what they said the last time, they're going to go do this. Or did you ever do that? Did you go, just following up with questions that let them know that you remember who they are. We don't really talk about treatment at all unless someone brings it up. And and knowing what we know about the dopamine surge with methamphetamine, I mean, I totally understand why people, I don't use it myself, but I totally understand why people would not want to stop using it. So I think it's a miracle when someone does, to be frank.
Yeah, absolutely. Christina,
Yeah.
what lessons learned do you have to share?
Again, really reflecting on or expanding on what both Peter and Sam said, having that engagement is really important, and listening. But I've also found curiosity is really important, asking questions. I might be a little it maybe sounds nosy, but I do ask people really blunt questions sometimes when they're first coming into the program and they've never met me before. Sometimes a lot of people who are coming to a syringe service program for the first time have never talked to a professional about their drug use. And I've made some people feel really off-put at first, just bluntly being like, oh, what drugs are you using? This is like if I'm doing a test strip, we're talking about test strips, and I'm saying, well, what drugs are you going to test? What drugs are you using? And some people are like, whoa, that's weird. But I think also talking about things and asking these questions in such a normal way really does help normalize that. And then once they've had that conversation, then they're like, oh, she's cool. Oh, they're cool. Oh, I can actually talk about this. And people might not come to the program with questions or say, oh, these are some things I'm concerned about. I'm going to ask my, the staff or volunteer at the program. But if I start talking about stuff or asking questions, people want to talk about it. People are so excited to talk about it. I've been working on this, a lot of these projects around stimulant user health the last 6 months or so, and I keep learning new things. So I'll go to my participants and I'm like, oh, I just learned this really cool thing. Did you know about this? And they're like, whoa, that's amazing. And then we have this conversation, and then that opens the door to a lot of things, and people are really excited about that. I also think it's really important having staff or volunteers or people working at programs who do have lived experience, who have, experience using drugs, even if they, might not have a substance use disorder or be in recovery or what we consider traditional recovery. Having somebody who has been around, who knows it, so we can use shared language. So using street language, talking You know, when I'm at public health, I can speak very professionally and very academically, and I speak very differently to my participants at the exchange, and that has been a game changer. So we have always had people with lived experience. We love our peers; those are such a game changer, because people who have been stigmatized their whole life or their whole substance using life or mental health life, they can tell when somebody's real. They can tell when somebody's kind of fronting or doesn't have that lived experience. And it just really changes once they realize that you are actually very similar to them. Maybe I have a little bit more porous boundaries than some providers are. I do talk about myself. I talk about my lived experience. I talk about my mental health issues and my challenges. And that has also really been a huge game changer. I've had some folks come back saying, hey, you know, I actually am going to look into, you know, maybe I have ADHD or autism. You know, I'm having anxiety. You've inspired me to go to therapy and to go see if I can maybe get diagnosed with something and I'd never thought of doing that before you shared. So I think being able to, you know, to whatever boundaries we feel comfortable and is appropriate for, you know, our position, a counselor or an FCDP would have different things that would be appropriate. But as a certain service provider, I can kind of have share a little bit about myself. And when we're peers, when we're certified peers, that is the cornerstone of that. And then also learning new tools and supplies. I mean, we're really learning that there are lots of things that we can give that are specific for folks who use stimulants. And that also, I think, is something that we can all start building into our programs.
That's great. What do you guys do when somebody comes into your program, if they do, who's maybe been up for a while, a little anxious, maybe making other participants uncomfortable? How do you handle that kind of behavior? I think that is often challenging for a lot of providers. So what pro tips do you have for that situation? Any of you?
I will start again, I guess. I think it depends. I've been up for too many days and I'm anxious and, you know, and dehydrated more than likely, and, you know, those things, or I'm in psychosis. And I am not going to speak to in psychosis because I'm not credentialed to do so. So I'm going to stay away from that one. But I've been up for too many days and I'm dehydrated and anxiety ridden and all that. I think if you have the ability to do so, to reduce stimulus, that would be the very first thing. So if you have a quieter area for them to be in, maybe dim the lights some, always making sure that whatever you're asking them to do or the situation you're putting them in, if that's all right, asking if they have something that they would like that would make them feel more comfortable, a fidget toy or something that they can cuddle with, or music they like, whatever it is. But yeah, reducing the just the overall stimulus, because it can be a lot, especially if I've gotten myself out of the house after that situation because I didn't know I need something, and it's just a lot can be coming in. So getting it is usually a good idea, because then you can find out what they're after and etc. and go forward that way.
Great. Sam, have you had any?
Yeah, I would agree. It depends on the situation. If someone is obviously just beleaguered because they're tired and worn out and all that, you just offer them whatever you can as far as the supplies or, you know, attention, listening, etc. If someone is disturbing other people, isolate, you know, get them out of the situation as quickly as possible, get them to a place where there's nobody else. We've done that several times. We do have one guy that comes in and he's yelling at himself, you know, abusing himself all the time. When in that situation, again, I'm like Peter, I'm not a professional who can deal with that. So we try to kind of get him in and out as quickly as possible. So it just relieves him of having to take that stimulus in. So, you know, get him supplies, get him on his way, because again, we're not able to deal with that. But yeah, most situations just kind of speed up the process or get them away from the general public and get them what they need.
Great. We've got some great questions in the chat that I want to make sure we have time for. And so I have one final question for all of the panelists. We'll start with Christina. Your top go-to harm reduction messages. Go.
Oh, that was one I hadn't prepared for. I was prepared for the
but you
other
know
question. I think my top, real quick, it would be talking about overamping, what people can do for overamping, talking about the signs of it, de-escalation. So, we give out these instant ice packs that people can use that can help cool their body down when they're overheating. I always have, water, nutrition shakes, and snacks. A lot of times when people come to me, they haven't, eaten anything. So that's something I can give right away and kind of start that engagement. Messaging. Gosh, maybe I'll give that Peter and Sam, and then maybe if I have a nugget, I'll come back.
Over to you guys. Other go-to harm reduction messages.
Oh, I would say, well, there aren't a lot of go-to harm reduction messages because everybody's situation is different. That said, it is the little things oftentimes that can have, especially I think with meth, it's the little things that over time can have a huge positive impact. So getting them the little stuffs like making sure that they're getting daily water intake and food and things like that, like Christina was talking about, but trying to get them to understand, to build that into their lives on a regular basis. And I think the one thing that is always sort of my mantra is I ask people to have a plan before they buy drugs. So if you map out what you're willing to do and not do when you're high, and you map out a schedule about when you're going to lay down and go to sleep or get rest or whatever, if you map all of that out and then do drugs, you're more likely to at least follow it, or follow it mostly, than if you wait to get high and go, now what do I do? Because that answer is not going to be one that's good for your health. Just isn't. So yeah.
Great. Sam, anything to add?
I would say the biggest harm reduction message that I would have is for wherever you're working with harm reduction, ask yourself, would anyone and everyone feel absolutely safe to be themselves walking in here? Is this the most safe space that I can be and create? Because I think everything else follows. When folks come into our space, they over and over again say, I thought this was going to be scary, but it's safe. I feel safe here. I think that's the most important part.
That's a great option for that.
One more nugget that I thought of.
Yeah.
I think a lot of my messaging is really the same as, a lot of the things that we've talked about today, and the curiosity and asking these questions. But another thing that is really important is that I think it's important for us to talk to other providers and other agencies or other types of programmings who are working with people who use stimulants and who use meth, to kind of also encourage them to have these conversations, and for encourage them to kind of look outside of the box and see how they can implement things that might be more specific to people who use meth. Also, like, what time of the day are services available? A lot of people who use meth stay up really late at night and are awake really late in the day. So a lot of our, 8 to 4 or 9 to 5 programs just don't really work for people. So being able to kind of see if there's ways that we can have later hours or weekends or kind of care for that. And also, with the first question with, if somebody's really agitated, what do we do? I think one of the things too is talking to them and seeing like, hey, do you want to be connected to crisis? It seems, I'm feeling some agitation, and trying to make that warm handoff, because a lot of times you can give them a pamphlet and tell them where. That doesn't go. So I do strive to, if someone does seem really escalated, is, you want to make a phone call right now? You want to call? I know this really great, intensive team that works with people with mental health challenges. Should we make that phone call right now? And doing that call for them, because making that phone call is scary. People have a hard time calling. So doing that for them and then handing the phone off for them to do their intake or continue the conversation has also been really effective.
That's a great nugget. All right, to get to some of our Q&A questions on the same topic of harm reduction strategies, Leslie asked about the conversation to help people consider transitioning from injecting to smoking as a way of reducing risks around injection. What's been your experience in talking with people about these options? If people ask about these options, how about injection safety? And I know two of you have already talked about that you're not and you're not allowed to give out smoking equipment, but that doesn't mean that people can't find other options. So what about these conversations or perceived risks between these different routes?
People are, I'll let Peter
Go,
go.
Christina.
People are always asking us if we have smoking supplies, so they want it. Almost all of the surrounding counties around us, their SSPs do give out smoking supplies. So people want it. We see, and this has been something that a lot of programs have seen, is that when you start offering these supplies, automatically people tend to reduce their injection use when things are available, because people use what tools are around them and what are available. So I see a lot of people kind of wanting to do that. As far as injection safety, there are some specific things around injecting methamphetamine compared to opioids that are a little challenging. For example, with opioids, you can inject in your vein or skin pop or go in your muscle. So if you don't have veins, there are other places that you can other ways to inject. Whereas with methamphetamine, it is incredibly painful and really harmful to inject not in a vein. So that's one real challenge that we have. So we can focus on vein health, on how to keep our veins healthy, how to use a tourniquet appropriately. A lot of people have this sense of pride, oh, I don't have to use a tourniquet. I'm saying, well, actually, it'll be a lot better for your vein if you do. And we have those conversations and kind of talking about safer injection, keeping things really clean to reduce infections, because we do see a lot of folks, with missed shots or abscesses. So that's one thing.
Great. Peter, did you want to add something to that?
Yeah. Oh, of course. Yeah, I think again, finding out where the person is at and what is motivating them is really important. I know when I first started using like 20 years ago, it was very hard I was my resource, I was homeless and already, by the way. And but anyway, so for me, when I got a bag of dope, I would consume it very quickly if I smoked it. But if I injected it, I could parcel that out and use less and have more control over my use. Again, I realize that is somewhat counter to the typical person. So I think it depends on what motivates them to use and that sort of thing. One of the things that I think most people would maybe find surprising is that injecting is, for a lot of people, is isolated. So if you inject, even if you're in a group setting, and MSM do tend to be in a group setting, they will all go to their individual corner to isolate it and inject and then come back together. Whereas smoking is more social. And if in fact you are coming from the direction of, I want to have them go from injection to smoking, that is one way to, that might be of interest. I think the other thing to keep in mind is that, again, there is no one best way. I also have a long time history with cigarettes, which I smoking. But anyway, so smoking for me is actually much more immediately detrimental to my body than it is to inject. Just is. So, so again, automatically assuming that if they use a needle that they're worse or doing more damage, or it is not necessarily a what's the approach to take. You need to find out their lives and what's working for them. But personally, I think they're both bad. I mean, from a strictly physiological point of view, consuming those drugs that way is both bad. But not for the reasons that most people think. It's not the drug, it's smoking. Is anytime you're taking smoke into your lungs, that's destroying your lungs, and most people don't train very well to inject correctly. So they're, yeah. Anyway.
Yeah, thanks for those. We will have a lot of great conversations this afternoon on more clinical type of interventions or medical interventions to help people reduce or stop their methamphetamine use. And I'm curious, and we heard a little bit about this from the panel earlier, that not everyone needs this level of intervention. And a lot of people do a lot of different things on their own to achieve these changes. So Sam, I'm kind of wondering like what you've seen people do on their own. We have one question in the chat of like, do people try using other substances like cannabis as a way to moderate maybe use of a more dangerous or a drug that they struggle with more? So what have you seen, Sam?
I can't speak to the people using cannabis, but most people who use, from what I have seen, people who use methamphetamine, there's, like we've talked about earlier, there really isn't another substance that's going to take the place of that high. Most people who stop using it, we don't see them anymore. I mean, to be fair, if they get treatment or they stop using, we don't know what's happened to them, but sometimes people will come back and say, hey, I've been clean for however long, whatever. But I don't hear often people using another substance to stop using meth, just because it feels, I mean, as we know, there are no drugs that take the place. Some people have been prescribed Adderall or another substance such as that by a physician, but yeah, the other panelists may have more information on that.
Okay, thanks. What do you guys, Peter or Christina?
Can you repeat the question?
It's just the idea that that we've heard already today, that there are a lot of paths that people take to make changes in their methamphetamine use, to reduce or ultimately stop, that don't always require working with a physician or in a formal treatment type of an intervention. So what have you seen folks do?
Well, I do think that a lot of people are self-medicating with methamphetamine for, undiagnosed ADHD, which I also think is, there's some complications of getting an actual diagnosis of ADHD and then getting prescribed medications that might really help and stabilize their lives once you have a established substance use disorder on your record. So I think, we know that exercise is great. People who can kind of get their exercise going, that has been a really good strategy. A lot of people I found have, being outside can be really healing. So working on finding ways to kind of change what their, maybe some of their social behaviors by exploring other avenues. People can get really nerdy on, and stimulants can help people kind of nerd out on things. So, but it is a little challenging, and we do hear people who are experiencing harms and they know that their behaviors are experiencing harms and they're kind of stuck with what options are available. So I think that is a challenging thing. I would love to see more harm reduction support groups, more groups where people who, are maybe in active use, like depending on how much you're using, to, maybe they're stopping use or using one drug but not using the other, to kind of share some support. But I know that lots of people have genius ideas of what they do to keep themselves safe while they're using. And I think that might be not within this topic, but there is a lot of wisdom. There's so many things that people who, have used meth or using meth do themselves. And again, that's where that curiosity comes in. Is almost everything I've learned has been from people who use drugs and from my participants and my friends and things that I've done. And so that's where those questions come in, and then sharing those cool tips.
Absolutely. Peter, what would you like to add?
I would like to take a slight left, just because there was something in the chat that came up that it's just caught my eye, and they were talking about how that going from a needle to a pipe for opioids reduces the risk of a fatal overdose. And we're curious if that is also true of for stimulants. And I think kind of goes back to the way that a fatal overdose or a fatal poisoning between the two substances comes about. And so the answer is no. There isn't, at least I don't know of it, and there probably isn't a lot of work on it, but I don't know a lot of data that would suggest that needles will automatically lower your, or I'm sorry, that pipes will automatically lower your chance of fatal overdose because the way it comes about in the body. If you're going to stroke out, you're going to stroke out. And there's so much other going on in your body too with the dehydration and things like that that causes problems with your health if you were talking about a fatal incident. So yeah, I don't think there's as clear of a correlation between the two routes of administration and fatal overdose.
Okay. Is there anything, thanks for that, Peter.
Mhm.
Is there anything you'd like to add in terms of strategies that people use on their own to reduce or stop meth use on their own?
Again,
or the use of cannabis or other substances?
yeah, I think it is a lot harder to find other substances to mitigate whatever is going on when you're trying to cut down on meth. For most people, they want to sleep. So the obvious answer to that is to take a stimulant. So yeah, so that it doesn't work the same as it does for maybe if you're trying to get off some other substance and then using meth to kind of bolster that. So that can be a real challenge, but I think I would like to highlight what Christina just said about being outdoors and things like that. And exercise. It is less of switching a substance to mitigate issues, and it is create a behavior change. Not just stop using meth. Can't stop there. Stop using meth or reduce your meth and go do this other thing. And that's going to really depend. Maybe it's art. I know a lot of meth users that are amazing artists that if they can get in a project, then they're not going to use meth. So yeah, there's a behavioral or an activity kind of thing that needs the component that goes to it.
That's great. All right. A big thanks to Allison, who has been dropping an extraordinary number of resources in the chat on this, including webinars that Peter has offered through our team, webinars that Christina has offered through our team, so many. And I think we have a slide, Erin, that might show where some of these resources live. So a couple of things. So if you want to watch a webinar on talking about more about engagement, there is the one that Peter offered for us a couple of years ago on positive engagement strategies. We do, through our center, we offer bi-monthly summaries on harm reduction research, what's coming out new in harm reduction research. And not long ago, we did one, a report specifically on new research, the latest research on harm reduction and methamphetamine specifically. And we'll get a link where you can sign up if you don't already receive our CEDEER monthly newsletter, which is how we help promote this. There's an opportunity for you to sign up to get more of the ongoing harm reduction research summaries. So tons to offer. So go through your chat and look through the resources. Again, all of these links we're going to be able to, we'll have on our Focus on Meth webpage after this, including the recordings for this. All the links will be there, one-stop shopping. Thank you, Allison. If you want to sign up for our CEDEER newsletter in order to get notices about upcoming trainings, webinars, and all of these resources, getting our semi-monthly newsletter is a great place to go. So I'm going to just offer our panelists in the last minute or two that we have. Are there any final messages and pearls of wisdom you would like to share?
Well, somebody put in a comment that they've had a difficult time finding resources summarizing self-care around these things. And I will say, yes, there is a really big lack of that, which is why I think ADAI has been doing this 6-month series. There are some bits and pieces, there's some old websites, there's like tweaker.org, which I think, old school harm reductionists maybe might know, but newer people might not know. Lots of agencies do have some specific things. I do want to highlight Next Distro. They are an amazing resource. They have so much information that is fantastic. The Harm Reduction Coalition has a really long resource on overamping in health, and it really goes into detail of that. And I am working on, these resources. That's something that I'm super excited about. If anybody has tips and pearls of wisdom and they want to share, I want to learn from you. So I can put my email in the comment or my phone number, but I would love to develop a little group. I've already been talking to some really amazing folks. I want to make something, and we all want to make something. So let's make it happen together.
That's great. Okay, Sam.
Yeah, just thank you to the panelists. I'm always learning from you guys, and thank you to ADAI, who does amazing work and always helps us when we are in need.
You're welcome. Peter, last comment.
Oh, absolutely. Just very appreciative to be here, and for all the work that we all do. And it's a constant reminder to know that we all come at this from a different place. And so try to hear the good stuff with the stuff that maybe is not pertinent to your own, lived experience and that sort of thing. But yeah, it's an amazing group of people, and I'm just very fortunate to count myself as amongst them. So
Indeed. Thank you. I am
Thanks.
proud to know you all as colleagues and friends. So thanks so much for sharing your wisdom with us this morning. That concludes the morning portion of our Focus on Meth Symposium. We will start again at 12:45, focusing on treatment medications and why is one so elusive for stimulant use disorder. All right, we'll see you back at 12:45. Thanks, everyone.
Thanks.